So we have just a small tidbit of chapter 17 to cover before we bump over to chapter 18. So let me get this set up here. So we left off with the leishmaniasis. We saw a little bit of this, and we mentioned a detail with this. Here we see the macrophage and the leishmania parasites. The stage of this parasite, we call these amastigotes. So these little circular parasites, and these are types of protozoal organisms. So single-celled eukaryotes. You can see, if I can get my arrow back in here, you can see their nuclei, multiple little parasites all within this macrophage. We're going to look in a couple of slides, not at a macrophage, but we're going to talk about tuberculosis and the potential for granuloma formation, where our body tries to wall off these organisms. But tuberculosis also does similar things, and we'll get into macrophages and live inside of a macrophage. So I wanted to back it up to just mention that before we jump ahead. So more details as we are thinking all of the stimulation with different types of cells sending out messages, trying to ultimately call in the troops. We've talked about mast cells and their release of histamine. Histamine's a vasodilator, so we can see in the instance that these cells recognize this, they start dumping the histamine. And if we move next door to figure B, as we look at these vessels, they are enlarged. We've got increased blood flow, more circulation, inflammation. And as this is happening, it allows the opportunity for some of these cells to wiggle through diapedesis. We mentioned this previously, and get in to the tissues, from the circulation into the tissues. So these phagocytic cells now can migrate and start dealing with the foreign invaders that have made their way into the tissues. And that's the idea with that. Multiple molecules, cytokines, are released from all sorts of these cells, stimulating the response. All right, that's the idea with that. So, as I mentioned, the TB, here we've got a section of some lung tissue, and what we're looking at in these two regions right here are large granulomas, tubercles, if you will, hence the name Mycobacterium tuberculosis. You get these formations where the body, as a defense mechanism, tries to encapsulate the cells, walling them off. This sets the stage for issues when we think about treating individuals with tuberculosis. We utilize antibiotics, but in these instances, it's not a quick course of antimicrobial agents. It's not 2 weeks of dealing with this. It's definitely much more prolonged. And the issue with that is these cells are hidden away, and the tubercles or the granulomas can start to degrade and release those microbes, so we can see recurrence of the infection when we maybe are feeling like we've got everything under control. All right, so that sets the stage for problems. It also sets the stage for issues with really dealing with the medications, because oftentimes individuals don't continue taking them when they start feeling better. After you've been taking them for months, right? We already know that typically happens with the normal course of it. Hopefully not typically, but sometimes happens with a normal course of antibiotics. And the last one, another parasite. I'm not going to go into details with this, but I sure want to. Elephantiasis, this is a chronic swelling. And another one that I've got a little bit of an issue with because really the elephantiasis are skin manifestations, changes in really the appearance of the skin, real thickening, kind of cracking, sort of really more resembling the skin of an elephant. All right. But we look at these guys' legs, this guy's legs here, and they're humongous, like an elephant, right? And I think oftentimes people try to just use it the same way. This really is the swelling that we're seeing is lymphatic filariasis. It sets the stage for these skin manifestations ultimately that progress to more of the elephantiasis. So the massive foot here or leg that kind of might think elephant foot isn't really elephantiasis, but for really all purposes, we're kind of just like, yeah, he's got elephantiasis. All right. So these are types of nematodes. There's a handful of nematodes that can set the stage for these situations. And ultimately, they get into the lymphatic system. They start causing blockages in the channels. Lymph is a one-way flow, one-way street. All right. And so as those channels get blocked, the lymph accumulates and can't get drained. The drainage system is blocked up. So the sewer's clogged. That's trouble. All right. And all of this is basically just accumulation of lymph, makes it comes out of circulation into the tissues and then should be drained off and is not. All right. So that's the idea. And almost always images you see, they're wearing some sort of flip flop, right? I also feel like this is sort of rare because I think for the most part, oftentimes when we see these manifestations, it's a single appendage, I believe. But obviously we've got both going on here. All right. His arms look okay. All right. And where that insect has taken a blood meal and inoculated, that's typically where we start thinking about it. So if it had fed up on the arm, you'd be seeing it up there, feeding on the leg accordingly. All right. So we'll see a little more of that stuff later. If you want more details, get into parasitology. All right. Lastly, when we think about some of our body's defense mechanisms, one very good strategy, I think, especially for stuff like bacteria, is to really crank up that thermostat to stimulate fever production. If we flip it back multiple chapters and think about all of the different types of bacteria, there are bacteria that like cold. There are bacteria that like us. And there are bacteria that like hotter temperatures. So those that like our body temperature, we call those guys what? Mesophiles. Yes. So A for the day, mesophiles like 37 degrees Celsius, right? Give or take a little bit, but that's what they like. And when we go to deviate from those temperatures, not so good. And if you ramp that temperature up a bit, especially when we're thinking higher extremes, that becomes more inhibitory to those microbes. So a little bit of fever, I oftentimes think maybe that's okay. Excessive fever has the potential to truly cause serious issues. You want to try to deal with that, all right? But low-grade fever really is the body's attempts to just increase that temperature enough so that the foreign invaders can't really tolerate that temperature, a little too hot, right? And then their metabolism is impacted, and ultimately the rest of what we've been thinking about has opportunities to get in and take hold. All right. So numerous things that could stimulate this. It could be some exogenous stuff, so materials, substances secreted from a microbe. Pyrogens are fever inducers. Pyro, right? Pyromaniac, right? Likes the fire, likes the heat, right? So fever inducer, all right? And a good example of that would be some gram-negative bacteria. Their outer membranes, the lipopolysaccharide layers, these are pyrogens and can stimulate a fever production. White blood cells also have the potential to release substances. In this case, now it's coming from our own stuff, so endogenous pyrogens instead of the microbes, the exogenous, all right? And so handfuls of these substances, cytokines, are released that stimulate fever production as well. So the ILs are interleukins, interferon, and then the tumor necrosis factor. All of these have the potential to ramp up that thermostat. So that's what we're seeing in this last bit. And PGE, oh man, I don't remember. Prostaglandin, maybe, something. Matters not. All right. That. So we have thought about the innate response. We've thought about numerous types of cells that participate in these responses. And oftentimes, when we think about immunity, we kind of divide it like we have done with these chapters. And we think about individual types of cells or different mechanisms, like our skin is a barrier, that we're really put under the umbrella of some innate response. We also can think about a lot of those cells that we have introduced as participants in what we describe as cell-mediated immunity. So all of these different types of phagocytic cells coming in and destroying things, cell-mediated, all right? Then we think about the other arm of the immune response, the adaptive response or humoral immunity. And we're really, and we've already said this, we're putting them in separate chapters. We're thinking of them as separate types of players. But really, when you think about an immune response, you would like to have as much help as you can get. So although we talk of them as separate things, they interact together. And those macrophages that we've introduced in our cell-mediated chapter bump right over into this and are going to stimulate other cells for the production of antibodies. So that really is the focus of this. How do we mount these responses? There are all sorts of different types of antibodies. We're going to talk about those, and they function differently. We will go through details with all of that. All right, all lending to levels of protection. And we also think about, with this type of a response, memory cells that are being generated that have the potential to respond very rapidly in a subsequent response. So it gives us a level of protection, right? Which we are thankful for. All right. So this image I always find really pretty disturbing, and it's, for me, super hard to relate to because I don't think any of us know anybody that has had polio, right? And through massive vaccination efforts, we don't think about it, all right? Just recently, I remember a little bit back going through this, and somebody piped up and said, there's still somebody living in one of these iron lungs. He just passed away just like a few weeks ago, I think. Not very far back. Crazy. And he spent, if I remember right, like 70 years in this iron lung. All right. Just laying there, hanging out. All right. Uh, that seems like a terrible life. All right. Uh, Truly. So, all sorts of issues with polio. And with that, the potential for paralysis, not everybody, but there are potentials for it. And here you can just see, as far as you can see, row after row of these iron lungs, basically these breathing devices for these people. And this is it for these individuals. It's not like you go into the lung and get some breaths and then you go about your business, go to your day job. This is your life, right? Uh, Crazy. So it was, the stuff before, it was interesting because he's, in this iron lung that is really pretty old, and they're just like, trying to get parts for that. Forget about it, right? Difficult. Uh, Really, yeah, disturbing. So we're going to talk vaccines and all of this as we move through here. But many things like that, we don't have really any way to understand it because we don't know anything about it, right? How can you relate to that? So this image, we're technically going to see this repeatedly through this chapter. We're going to talk about it with some different ideas as we move along. I'm going to give you a few uh, tidbits with that as we're looking at it right now. So there are numerous things that we can think about in this situation. It could be coming in contact with some sort of pathogen, getting sick, recovering, and then seeing it again. It could be a situation where we think about getting a vaccination. That could be a same sort of an idea, and a booster shot, right? Really what we're looking at are a mixture of antibodies that are being produced. And in a little bit, we're going to see this subdivided a little. So we can see different classes of antibodies and really what's happening in kind of a little more detail. All right. So all of this, we don't have any sort of units. It truly depends on some of the agents, whatever they may be, as far as how good of a response we see and the length of it. Although we have a few hints about some of this. All right. And the level of antibody, this would be basically taking a sample from the patient, a blood sample, and looking at the serum. So your red blood cells are circulating around in all of this fluid, and the serum, the plasma, the fluid within it, the serum has all of those cells removed. And what you're left with is just that liquid. Your proteins, antibodies are soluble in that. They're dissolved within that, if you will. All right. They're not cells. All right. They're in the serum, and there's boatloads of different types of proteins. All right. Some of them being immunoglobulins or antibodies. All right. So what we're looking at are those antibodies, the levels of antibodies, and we can measure absorbance values to give us ideas as far as how much is being generated. So this is also kind of like the bacterial growth curve, where we see a bit of a lag phase and then a peak and a decline, kind of the same sort of an idea. So if we're thinking an infection, our initial exposure, our cells haven't had time to do anything about this, if this is a novel thing, all right, our first exposure, it takes a bit of time for all of the processes that we've already kind of looked at, like that wound that happened, all right, and the microbes getting in. It takes time for those cells to see it, to start sending out those messages, to start mounting a response. And then once those B cells get all of the proper cues, we start releasing some antibodies. All right. So a week, give or take a little bit, we might start seeing the hint of some antibodies being produced. All right. And these levels of antibodies increase as we are trying to combat those pathogens. We hit a peak in that primary response. And at this point, the majority of those foreign invaders are probably being targeted very rapidly. All right. And their demise is right around the corner. All right. And as we start to get that infection under control, we're reaching the peak of this response. We've got everything dealt with. Those other cells are coming in and mopping up some of the debris. The levels of antibodies start to decline. All right. They still have a little bit of activity, if you will. We can detect them. Depends truly on the circumstances. In some instances, we may see these levels going down to near zero. And in other circumstances, they may remain a little bit elevated. There are all sorts of different ideas with vaccinations, and some vaccinations, you get a shot, and then a little bit later, you get another shot, and then they say you're good to go, right? Other vaccinations require boosters repeatedly. Tetanus is a pretty good example. They say about a decade, although it's kind of hard to say if you really need all those extra booster shots or not. But knowing what tetanus does, a little shot seems a lot better than chancing it, right? So, but definitely there's variation with the types of immunity that is warranted, whether it is lifelong or requiring boosters. All right. So, regardless of whatever happened, although we're talking an infectious agent initially, the second exposure, so another bout with that same thing, at this point, we're going to see similar stuff like the previous chapter, cells coming in and recognizing. But at this point, we've already been primed. These immune cells that are capable of secreting these antibodies, they're still around as memory cells. And now when this foreign invader shows up, we've seen you before and we're already prepared. And so we don't see this big lag phase needing to get everything primed. It's already there. And so the response is very rapid and considerably more pronounced. All right. The level of antibody is much greater than the first exposure. And the result of that are all of these memory cells that are already present. They start differentiating back into the plasma cells, the antibody secreting factories, and we ramp up these populations. So the second exposure, we see a big boost, and then it starts to decline again. This drops off, but at this point, we see it remaining elevated, higher level of immunity. This is oftentimes when, if we're thinking vaccinations, where we might start thinking you've got some immunity, you've got some protection, all right? Likely, all right? And with vaccinations, typically needing a booster shot ensures that those levels are high enough, all right? So there are other ideas with this, and we could think of it like an allergy, an allergic reaction. And we could think of it as your first exposure to that. you don't really recognize any sorts of issues. Symptoms, not having them. All right. Your first exposure to that allergen, your body just sees it, gets primed for it, and the next exposure is when you feel it. All right. So with an allergy, this initial exposure we call the sensitizing dose. And the second exposure we call the shocking dose. That's when you know it happened. All right. So that first bit of when you developed an allergy and you felt the symptoms wasn't your first time in contact with it. It's really the second. All right. And now you mount that response, the allergic reaction as a result of antibodies stimulating stuff that would technically don't really want getting stimulated. All right. So we'll hit allergies a little bit later. All right. Pretty interesting. So when we think about recognizing whatever it is that's foreign, we've talked about all sorts of different molecules on the surfaces of cells that we utilize to detect things, to communicate with these respective receptors. And when it comes to a pathogen or an allergen, whatever it could be, we think of these things that are capable of being recognized as antigens. And on those antigens are specific bits that stimulate something, some sort of a response. We call the part of the antigen that's really responsible for doing that stimulation, we call them epitopes. All right. And in this example, we've got, and so there's all sorts of different things that could be antigenic, but oftentimes when we think about antigens, the majority are types of proteins. And typically, to be a good antigen, you should be something that is very different, foreign. The more foreign, the better, right? Stuff that's your own, you would sure hope isn't serving as an antigen and stimulating some response, all right? But it can, all right? So these epitopes are ultimately the fingerprints, if you will, that our antibodies are going to be able to recognize and stick to. That's the idea. And then there's all sorts of things that result after those antibodies have recognized. All right. So we will see some of this in a second, but this to me looks like a bacterium. All right. And little bits on the surface of the bacteria. And we could call those little bits antigens. And the specific shape of that bit, a specific epitope, right? Something we could recognize. We would expect that there's probably more than one thing that we could mount a response against. This same pathogen, whatever it is, Streptococcus pneumoniae, Seminara 2, right? Maybe there are a dozen different types of proteins on the surface of these cells that all could stimulate some sort of antibody response. All 12 of those we would call epitopes, and they're all different shapes, different pieces, right? So things that are recognizable, all right? With that, we could think about our macrophage, right? And we're going to see we already showed some phagocytosis, but we're going to see it again. We could think about our macrophage engulfing something, whatever it is. If this gray guy is the bacterium, if it engulfs that, blowing it apart, some of those pieces, the epitopes, aren't going to just get degraded or dumped out with the trash. Those little epitopes are going to get studded on the outside of that macrophage's surface, right? And those are going to stimulate other things. So the epitopes get transferred, if you will, all right? This is what's, when that macrophage is doing show and tell, this is what's being shown, all right? And it could show all sorts of different things. Look at all of the stuff I brought for show and tell, right? And different cells will recognize these respectively. We're not going to have one cell that's like, oh, sweet, I'll make all three of these. It makes one. It's specific, all right? But now we're making three different cells, making three different antibodies against the same player. We've got multiple ways to try to target. And that's important. I would hope, right? Important. So there are lots of things that these antibodies can do, but the idea, one main idea, is to interact with these epitopes. I'm going to show you different antibodies here in a second, all right? This is a generalized image, all right? And likely this type of antibody, we'll define in a second, is IgG, all right? A single Y shape, all right? So these are the antibodies, all right? The little Ys, all right? And with that, we'll show some more anatomy of an antibody in a second. There are really two regions on this antibody. The tail of the Y, it's important, all right? And the top of the Y, and this looks like a Y right here, but our Y up at the top, these regions on the end of your Y are what we call antigen binding sites. These are the regions that want to recognize what was being shown at show and tell, right? And we've got different antibodies for our respective shapes, our epitopes. One thing that they can do is glom on to different ones. So we've got it with this one and with that one, and we would call this an agglutination reaction. We're clumping something up, all right? If these were red blood cells, we would call it hemagglutination, clumping of red cells. And that could be a transfusion reaction. So a type A person's given type B blood, not good, right? And antibodies against B are recognized in the recipient that just got that B blood, and they clump it all up. Now you get blood clots that start to form. Hopefully that stuff gets destroyed, all right? But it sets the stage for some serious reactions, all right? We talked complement before, all right? We're going to talk complement again. But this other region, the tail of the Y, is important because it is like a beacon for part of the complement mechanism. The classical pathway relies on antigen-antibody interactions. And if you have this agglutination happening, you've got all of these antibodies with their little tails wagging like a dog. Those complement proteins recognize it, and the complement cascade ensues, and these things get destroyed. So that transfusion reaction, you hope complement activates and destroys those blood clots very rapidly. All right. So we'll get to those details in a bit as we move along. So a little bit of the anatomy. There are multiple classes of immunoglobulins, but this is the idea. We will see them with multiple ones or a single, all right? So our Y is really multiple strands, all right? Different proteins coming together. The light chain in green and the heavy chain in purple, all right? And these light chains interact with the heavy chain and form some covalent bonding, disulfide bonds. So there are cysteines in the amino acid residues making up these protein chains, and cysteines that are adjacent to one another can covalently bond, and that gives us a tight glue to hold these molecules together. We got another disulfide bond holding the two heavy chains as we move down both sides, holding these together to create that Y. All right. So up at the top, the business end of the antibody. All right. Up at the top is this antigen binding site, FAB, for the antigen binding fragment or fragment antigen binding. And the crystallizable fragment, the FC region, that's the tail. All right. And there's all sorts of things that we can crystallize and examine, DNA, proteins, especially, and then looking at them as you shoot x-rays at them, the diffraction pattern can give you some images of what those protein structures look like. This is a computerized three-dimensional model. I think maybe a little easier to imagine than an x-ray diffraction pattern. I see those pictures of Watson and Crick, well, Rosalind Franklin's picture that they stole of that double helix, and it's not really the double helix you're seeing, but the diffraction of, yeah, whatever. Hard to wrap my mind around that, right? This a little bit better. So green, the light, purple, the heavy, the FAB region, the FC region. And with that, this site is a variable region, all right? So this one B cell that's been stimulated, and we'll go through this process, sees that specific epitope, and within its machinery is capable of producing this one antibody, all right? There are numerous genes involved in the production of antibodies, and we can basically, by how we're going through and modifying the message, we can make anything, all right? This is like needing a key made, and you go to wherever it is you're going to get your key made, all right? Ace Hardware, all right? You take your key in, and they make you one, right? It's an exact copy, right? My key is like that epitope, and they make me a new key that matches exactly, right? Now you're good to go, right? And this antibody sees that specific thing, right? And all of these different genes, as we're taking little bits or bigger bits or whatever it is, gives us an assortment of amino acids that gives you every single key you could ever want made, all right? There you go, all right? You got to get primed, right? We need to see this stuff, all right, in order for that key to get made in the first place. But the ability to make it is harbored within the DNA, all right? It's there. Crazy, all right? So, told you there's a handful of different types, all right? IgG, and we can see all five of them up here. IgG, and it's immunoglobulin G, M, A, D, and E, all right? The little g immunoglobulin, and then there you go, all right? So we showed just that image of the antibody, and I say, yeah, this could be IgG, because it's a monomer, all right? A single Y, all right? I'll go through a little more of this in just a second. IgM is considerably larger. It's a pentamer. So it's 5 of the Ys all cross-linked together to give you this big cog that's got the ability to look at a lot of epitopes. It's going to be the same thing, right? I'm only looking for triangles or circles or whatever it was from that image, all right? But I could snag 10 of them, if I truly could, all right, these guys could snag two, all right? IgA, this one is a little bit different. It's a secretory antibody, and in the secretions, it's a dimer, right? In the circulation, we could see it as a monomer, like our IgG, but they pair up and cross-link together and become the active bit. So these are important in like mucus secretions, providing levels of immunity, recognizing, all right? It's important. IgD and E are like IgG, all right? Monomers, all right? As I mentioned, if those were bacteria and getting glommed onto, it's IgG, all right? IgD is a little different. It's a molecule that's on the surface of B cells, all right? We'll see more of this in a minute. IgE is important with stuff like allergies or parasitic infections. Levels of IgE are going to be elevated. And if we were talking an allergic reaction instead of a bacterial infection, I would have said these antibodies are IgE, not IgG, all right? Because I would expect a boatload of these glomming onto those epitopes and stimulating other responses, all right, versus this, all right? So sizes and those that are monomers are pretty close to the same size. The dimers and the pentamers, much larger than the individuals. So IgG is the main player, about 80% of the proteins and of the antibodies circulating around. It's not the proteins. I think albumin is going to be your dominant protein circulating around. But 80% of the antibody are these, all right? IgM, a little bit lower. These are super important, these two, all right? So about that. In the secretions, the dimer, in the circulation, monomer, about 13%, all right? And then the D and E, much lower, all right? With this, it's going to be elevated if there's a parasitic or allergic reaction, all right? But normal situations, low, all right? So now for the details, all right? IgG, there's lots of things that make IgG important, but first off, IgG is the only immunoglobulin that's capable of crossing the placenta. So while that little dude's still cooking up in the oven, all right, IgG is able to cross the placenta and provide a little bit of mother's immunity to that developing kid, all right? When they hatch out into the world, they have IgG circulating around from their mother. A little bit of protective immunity is given to the child, all right? Little bit, not the others, just IgG, all right? Complement for that classical cascade, both IgG and IgM are important in fixing complement and stimulating the destruction of those things with those tail bits, the FC regions that stimulate the complement. And this looks like those tails aren't available, but they are, all right? Complement can see that. So the functions of these, and there's a lot of similarity with G and M, they can neutralize. So maybe toxins that are being secreted, they could take those out of commission. They cause agglutination, the clumping up of stuff, whatever it is. They fix complement, stimulating the destruction. IgG acts as an opsonizing agent, and that's basically like putting a tag on it, all right? To opsonize it, you coat it with these antibodies, and now the FC regions are like little flags. It's like the forest with, the ribbons tied around the tree to tell the, Forest Service, these trees need cut out of here, right? They opsonize marking something for destruction. All right. They're also important in antibody dependent cell mediated cytotoxicity. We'll go through details with that. Well, Monday. All right. So M is doing the same stuff, activating, neutralizing, agglutinating, monomer forms. So individual bits also can serve as B cell receptors like our IgD. All right. And this is important when we think about memory cells. Now we've got a piece of this on a B cell that's just hanging out minding its own business, waiting to see it again. But I've got that same fragment poking on the outside. So if it shows up, I'll link up with it and immediately start spewing out antibody. All right. Pentameric antibody. All right. So the IgA in the mucus secretions, super important for neutralization. It helps to trap pathogens, taking them out of commission and not giving them the opportunity to actually take hold. Obviously, it's not 100% effective, but it's there. All right. The D on the surface of B cells. And lastly, RE. All right. We see this. And this with the opsonizing. I look right here. The FC region of it combined to phagocytes. So that's the opsonization. That can stimulate other cells to recognize, link up, and destroy. Opsonized. All right. With our IgE, it combined to the surface of mast cells and basophils. I already described their issues with that and important in allergic and parasitic infections. And IgE is really what's stimulating a lot of this. All right. So activating basophils and mast cells, and that in turn can help try to deal with parasitic or allergic reactions. And often it's also where you get your symptoms as you're dealing with that. Okay, I will quit at that. Farewell, good day. Like I said, I will get pack back adjusted so you can complete it. All right. Have a good weekend.